trigeminal neuralgia as pain physicians is something that we see. So this is like pretty much our bread and butter. So we do see a lot of trigeminal patients, at least in my practice, I see a reasonable amount of trigeminal patients. So let me introduce you to the topic. So as young pain physicians who are learning trigeminal neuralgia, at the end of my talk, what I would be happy with is if you know the algorithm well, in terms of which patients of trigeminal to be treated conservatively, which patients you will offer an pain intervention, and which patient you will refer for surgical repair. That's the main aim of the talk. So I'm sure all of you have some baseline knowledge about trigeminal neuralgia. So at the end of the talk, in my talk, I'd be happy if you have the algorithm very clear in your mind. So we'll talk a little bit about pathophysiology. We'll also talk a little bit about how to do conservative treatment with pharmacological methods and how to do interventions, what type of interventions are there from pain. Right. Now, definition-wise, trigeminal neuralgia is a predominantly or almost always a unilateral painful facial condition where patients can have pain along one or more of the branches of the trigeminal nerve. Now, when I say predominantly, usually about 98% of time, trigeminal neuralgia is unilateral. About 1 or 2%, it's possible that they have bilateral disease as well. So, why so much fuss about trigeminal neuralgia is it's an extremely painful condition, sometimes referred to as a suicide disease. So, the pain can be very severe, and also a bit of depression and anxiety is associated with trigeminal neuralgia. Now, this is the epidemiology. Now, slightly more incidence in ladies. Now, this is typically a disease that we see in the elderly population. So, when I say elderly, most patients come at 50, 60, 70 years of age group. Although I have to admit that off late, we are also seeing patients who are relatively younger. So, majority of the time, these patients are 50, 60, 70 years of age, and they have a serious deterioration in quality. So, what happens is, initially, these patients have either V2 or V3 or V1 pain unilaterally. And then initially, it's only for 1 second. And as time goes, this disease becomes worse and worse. So the pain tends to stay for longer. So the pain-free period gradually reduces. And eventually, it becomes a type of a chronic pain, which is there almost always. And also, a lot of times, we see that patients who initially come with, let's say, a V2 neuralgia or a V3 neuralgia, eventually become V2 plus V3 or V1, V2, V3, all three together. Now, typically, this group of patients have a very brief, at least at the beginning of the disease, a very brief electric shock-like pain. So they have a shock-like pain which lasts for about 1 second, and then that pain is very severe, and then there is no pain for some period of time. So it is also possible that initially these patients have pain only during the winter months or something like that, only when exposure to cold. Sometimes patients will give history that when they are inside a bus and cold air is hitting their face, only then they're getting pain. And gradually, this becomes quite chronic. Now, sometimes in terms of diagnosis, there are a set of questions that you want to ask, whether to know whether this patient is indeed trigeminal neuralgia or any other type of facial pain. So one of the common things is whether this is a very brief pain that starts initially and then it becomes chronic, whether the pain is almost always on one side of the face, and if there are any autonomic symptoms like watering of the eyes or watering of the nose, then the diagnosis goes towards something like a cluster headache. Now, once in a while, as physicians, you'll get confused whether it's indeed cluster headache or sometimes V1 neuralgia. So cluster headache and trigeminal involving the ophthalmic can be sometimes confusing. So remember that cluster headache pain is retroorbital and it's associated with autonomic symptoms like watering of the eyes and nose, whereas V1 neuralgia, there is no autonomic symptoms. And usually cluster headache is much more severe than trigeminal neuralgia. Right. So according to the International Headache Society, we classify it into classical and secondary. So classical is the majority. Now, in classical, there are a group of patients in which you are likely to find a vascular compression of the trigeminal neuron at the level of the root entry zone. So sometimes you'll find MRI reports which say that the superior cerebellar artery is compressing the trigeminal at the level of the root entry zone. Once in a while, you may not find it. So if the MRI, if you don't find anything, sometimes it's assumed that the compression is microvascular and it is not documentable with MRI of the brain. There is also a smaller category of patients who are secondary trigeminal. These patients may be having diseases like carcinoma, systemic sclerosis, Lyme's disease. So it is this category which is having secondary trigeminal neuralgia, which are likely to have bilateral disease. So sometimes in carcinoma, we do find patients who are having bilateral secondary trigeminal neuralgia, but by far unilateral classical trigeminal neuralgia is much more common. Right. So the etiology at this point of time, from what we understand, seems to be mainly neurovascular or microvascular compression at the level of the root entry zone. So as the nerve comes out, the superior cerebellar artery and the trigeminal nerve root are very close, and the superior cerebellar artery is pulsating. So along with the pulsations, it keeps repeatedly irritating the trigeminal nerve, and this creates an ectopic focus which starts transmitting shock waves or pain signals that go to the brain. So this seems to be the pathophysiology, and the superior cerebellar artery is the most commonly offending. Now, you do find that as time goes, the remission and the exacerbation, so the remission seems to be reducing and the pain becomes gradually more chronic. Right. So coming to the anatomy, so you do find V stands for the fifth cranial nerve. V1 is ophthalmic. So if you see the nerve that comes out from the brain stem, and then you have the trigeminal root itself, and then it comes down and forms the ganglion here. So the ganglion is situated in the Meckel's cave. Now from the ganglion, you have the V1, which is the ophthalmic, which comes out through the superior orbital fissure. It supplies the region around the eye, and then the terminal branch of V1 seems to be supratrochlear and supraorbital. Now the V2, which is the maxillary division, comes out like this. From the V2 division, you have the spinopalatine ganglion that is hanging down, and it's in communication with the maxillary. The V2 supplies the region between the eye, nose, and the upper lip, and the V2 maxillary division eventually becomes the infraorbital nerve. The V3, which is the mandibular, comes out through the foramen ovale. It supplies the lower jaw and also the temple region and the region before the ears, and this becomes the infraorbital and the mental nerve eventually. So the supratrochlear, supraorbital are terminal branches of V1, infraorbital is terminal branch of V2, and the mental and the inferior alveolar nerve are branches from V3, which is the mandibular, right? So just to give you an idea of the perspective. Now remember, V3 goes up all the way to the temple here. So common nerves that we see are V2 and V3. So the black part of this diagram is sensory, the green is motor. So the ophthalmic, we talked about superior orbital fissure, it's a pure sensory nerve. Maxillary coming out through the foramen rotundum, again sensory nerve. Mandibular coming out through the foramen ovale has got a motor component, which is the nerve that supplies the masseter muscle. So mandibular is mixed, ophthalmic and maxillary are sensory. In terms of anatomical location, medial to the Meckel's cave, you have the cavernous sinus, superiorly you have the temporal lobe, and then you have the three branches, ophthalmic, maxillary, and mandibular in front. So this is your anatomical location here. So in order to reach the Meckel's cave to do a percutaneous procedure, we enter from the cheek, go through the foramen ovale, reach the Meckel's cave, and if required, we do an RF ablation or a glycerol injection or balloon compression. So access to the Meckel's cave is through the foramen ovale, which we achieve by using the submental view when we use fluoroscope guided procedures. So in terms of distribution, so you know which is the distribution. I've already showed you in the picture. So this is the distribution of the ophthalmic. This is maxillary. So this region is covered. So these two are pure sensory nerves. Mandibular also supplies, other than the inner cheek, temple, lateral scalp, it also supplies the anterior 2/3 of the tongue, lower lip, and parts of the meninges as well. Now, the mandibular also supplies motor to the masseter, which is one of the muscles of mastication on one side. So, this is your area of distribution of the pain. Now, studies are suggesting that V2 plus V3 is more common. Next is V2, next is V3. So, majority of your patients are going to be V2, V3, or a combination of both of these. So, you will treat these patients conservatively. In MRI or MR angiogram, you may be able to pick up some blood vessel, which is usually the superior cerebellar, touching or forming a vascular loop around the trigeminal nerve root itself. Now, in terms of treatment, the treatment could be medical or surgical. So, we'll talk about medical, the surgical aspect, the neurosurgeon after me will be talking about. So, in terms of medical, the diagnosis, most of the time we confirm clinically, we may confirm it along with the MRI of the brain. Once we do treat these, once we start the treatment for trigeminal, basically we are going to talk about pharmacological management, basically neuropathic pain drugs. So, still the drug of choice is carbamazepine. So, carbamazepine we have been using for close to 40-50 years now. So, the common available brands like Tegretol, Zeptol are all carbamazepine. So, usually we start with a 200 milligram dose, which we gradually build up, and we can go comfortably up to 1200 to 1800 milligram of carbamazepine, gradually built over a period of time. The things that you'll be careful when you're using carbamazepine are, one, very rarely there is an allergic reaction called Stevens-Johnson syndrome that you'll be careful. Other common side effects are aplastic anemia, thrombocytopenia, leukemia. So these things are possible. So every 3 months, you'll be checking total count, differential count, hemoglobin, CBC. Every 3 months, you have to repeat. And every 6 months to 1 year, you have to check your liver function test because these patients are going to be taking these medicines chronically. So you will have to titrate the dose depending on the response. So the first line drugs that we use are carbamazepine and oxcarbazine. Now, oxcarbazine is a slightly better version of carbamazepine. Oxcarbazine is available as oxetol. It's 150 milligram dose. Again, you can go comfortably up to 900 to 1200 milligram of oxcarbazine. So these are your first line drugs, basically falling into this category called anti-epileptic medication. The next group of medications could be phenytoin, gabapentin, or even pregabalin. So these are your second line drugs. The third category of drugs that we use could be baclofen. So the first line drugs are carbamazepine or oxcarbazine. Second line is phenytoin, gabapentin, or pregabalin. Third line drug could be baclofen, which is a centrally acting muscle relaxant. So these are your typical drugs of choices. Sometimes this drug titration is done by pain physicians, sometimes it's done by neurologists. Now, patients who don't respond to neuropathic pain medicine, here is where your algorithm comes into view. So, I'll give you a very simple algorithm that you can follow to differentiate which category of patients you will do what. So, you have patients who are diagnosed as trigeminal clinically, MRI done, and if they are happy with pain medication, that is neuropathic pain medicine is giving good relief, these patients will continue to stay with neuropathic pain medicine, which is titrated over a period of time. Okay, so this is one category. Now, if these patients, in spite of taking adequate dose of neuropathic pain medicine, are not happy and pain is still persisting, or this group which is allergic to neuropathic pain medicine are the ones in which you will think about plan B. So the ones that are not responding to neuropathic pain medicine, we'll divide into two categories. One is patients with neurovascular compression in the MRI, the patients without neurovascular compression in the MRI. So the ones without neurovascular compression that is documented in the MRI, these are good candidates for percutaneous procedures, which could be your glycerol injection, balloon compression, radiofrequency ablation, or even neuromodulation. The ones that they are not responding to neuropathic pain medicine and have documented neurovascular compression in the MRI. This category will divide into two groups, less than 50 years, more than 50 years. So some books will say 40 years, some books will say 50 years. So patients not responding to neuropathic pain medicine who have documented MRI compression of the trigeminal nerve root less than 50 years are good candidates for microvascular decompression, which is the surgery. Now, the surgery has got some amount of risk in terms of mortality and morbidity. It is obviously a craniotomy, which we are going to see in detail further. But if it is successful, could be a long-term relief, possibly even a lifetime relief. The percutaneous procedures, even though are less risky daycare sort of procedures, but they have typically a lifespan. So typically when I do an RF ablation, the effect may be there for anywhere between 2 years to 5 years. So depending on the operator, depending on your technique, the procedure has got a time period usually, because after we do the thermal ablation, the nerve can regenerate. So it is ideally a good procedure if your patient is 50 plus, because you don't want to do a RF ablation in a 30-year-old because he'll come back when he's 34 or 35, and how many times you're going to repeat it. So the call is taken based on the finding in the MRI and the age. So a good patient for microvascular decompression is not responding to neuropathic pain medicine, documented MRI finding with the neurovascular compression less than 50. So anybody above 50 are good candidates for percutaneous procedure. So I hope the algorithm is clear. So in terms of treatment, you have three promising procedures. First one is a retrogasserian glycerol injection. So what is retrogasserian? So this is the traditional technique which was used by the neurosurgeons. So what they do is they put a needle through the foramen ovale, they go past the Meckel's cave, go above the Meckel's cave, and they go into the dural sleeve. Okay, so the dural sleeve is covering the trigeminal as it comes out. So they go into the dural sleeve, aspirate CSF, and then inject about 0.8 to 1 ml of glycerol. 0.8 to 1 ml of glycerol is hyperbaric with respect to CSF. So it will accumulate around the nerve root. So after they put the glycerol injection, they'll take the needle out and make the patient lean forward for a duration of about 30 minutes to 1 hour. So when the patient leans forward, because of gravity, the glycerol will accumulate around the trigeminal nerve, and these patients have good analgesia. So this is retrogasserian glycerol injection. The next option is radiofrequency ablation, which at this point of time is considered as a procedure of choice. So the other advantage with radiofrequency ablation is you go through the foramen ovale, identify each of these nerves, you can do a sensory and motor stimulation, and then confirm and then ablate only one of those nerves, and then these patients have good relief. Depending on your the way that procedure is done, the relief can be anywhere between 1.5 years to 3 years or 4 years. I've had patients who cross 5 years. I've had patients who cross more than 5 years as well. But the factors depend on a lot of operator derived factors. So usually we say anything between 1.5 to 3 years for a radiofrequency ablation. Balloon compression, again a technique which the neurosurgeons do, where you put the needle and mechanically ablate the trigeminal ganglion. So you crush the trigeminal ganglion. So balloon compression is a good procedure for ophthalmic division, which are not good candidates for RF ablation. There is also a role for neuromodulation. So we'll quickly see each of this. So this is your anatomy. So this is your Meckel's cave. So this is the foramen ovale. So the needle has to go through the foramen ovale into the Meckel's cave. So this is typically the way the patient is positioned. So you can see this is the tilt of the radiofrequency, the C arm, and I'm coming from the right side. So I'm a right-handed operator. So I'm going to concentrate on the patient's right cheek. Okay, so this is about 30 degrees quadrat and about 8 or 10 degrees ipsilateral oblique. And I'm going to enter the right side. So usual entry point is about 3 centimeters from the angle of the mouth. Right. So this is the direction in which the needle enters into the cheek and it goes. So this view is called the submental view. So what are you expecting to see in the submental view? So you're expecting to see something like this. So this is a submental view. So this is the TM joint. This is the angle of the mandible. This is the chin. So mandibular notch is here, ramus of the mandible. So you can see here, this is the foramen ovale. So you have to enter into the foramen ovale do a sensory and motor stimulation. After you do a sensory and motor stimulation, then everything is satisfied. You give local anesthesia, numb the place, and then do an RF ablation, which is a thermal ablation. So usually the temperature we are looking at is 65, 70, and 75 degrees. I usually do 1 minute lesions, about 4 or 5 lesions. So you can see this is the foramen ovale. I have kept my marker here. So this is my foramen ovale. So my needle is going in through the foramen ovale. So you can see my needle entering the foramen ovale here. And then this is the lateral view. So this is posterior, this is anterior, this is superior, this is inferior. So the needle is entering in like that. This is the pituitary fossa, clivus, petrous part of the temporal bone. This is C1, this is C2, this is C3. This is the TM joint. So the needle is coming in like that, and the needle tip is somewhere here. Auditory meatus is here. Okay. So this is a lateral view again, anterior, posterior, superior, inferior, pituitary fossa, clivus, petrous part of temporal bone. TM joint is here. This is the auditory meatus. This is the needle. So you can see the needle tip is here. So depending on the stimulation, you may either enter deeper or be more superficial. So this is your trigeminal lateral view. So quickly show you how masseter contraction looks like. So right side entry, so with motor stimulation, this is typically your masseter contraction. Okay, so I hope that is clear. So this is your entry into the foramen ovale on the right side. So again, another needle entry into the foramen ovale. So if you can see this image here, so this is the foramen ovale entry on the right side. So this is the lateral view, needle coming in here, pituitary fossa. So this is your entry into the Meckel scale. Again, more images of trigeminal entry. So typically, sensory stimulation 50 hertz, motor stimulation 2 hertz. This is your typical lesioning. Okay. In balloon compression, you put a needle. Through that, you put a Fogarty's catheter. You inflate the Fogarty's catheter with contrast. So the Fogarty's catheter is sort of inflated here, where you mechanically compress the trigeminal ganglion for a period of up to 6 minutes. And this will block both sensory and motor function in all the 3 nerves. So balloon compression is a technique which is suitable, especially if there is ophthalmic involvement, because ophthalmic involvement is not ideal for trigeminal, for RF ablation. So if you see, we talked about 3 techniques. One is glycerol, one is RF ablation, one is balloon compression. So for percutaneous techniques, there are 3 promising options. One is glycerol, one is RF ablation, one is balloon compression. In terms of relapse rate, glycerol is higher. Success rate, the RF and balloon are reasonably good. RF is almost always associated with facial numbness. Anesthesia dolorosa can be seen with RF and balloon compression. Corneal anesthesia is very common with RF ablation, so that's why it's not a good option for V1 neuralgia. And motor weakness is more common in balloon compression. So these are the factors that you keep in mind before deciding the block. There is also a small role for neuromodulation. So sometimes you can put stimulators in the supraorbital, infraorbital nerve and keep your battery or impulse generator below the clavicle. You can see stimulators supraorbital and infraorbital. So these are not my images. So there is a role for neuromodulation. There is also a role for stereotactic radio ablation, which is a concentrated radiation technique, which may be called as gamma knife or cyber knife, which is a concentrated radiation technique. Obviously, we are going to see more in terms of surgery in detail. So there is microvascular decompression, which is a normal surgery. And then there is also endoscopic surgery. All these are options. So if you see evidence-wise, RF ablation is a good option as a first procedure, especially suitable in elderly population, especially for patients who don't have any MRI compression. So these are your ideal candidates. RF ablation is suitable for also for elderly population as well. MVD recommended for patients with clear radiological finding in younger age group. So that is less than 50 years, microvascular decompression is a good option. So these are the various complications that you will see. One with surgery, then with RF ablation, then with glycerol injection, then with balloon compression. So the things that you should know about are numbness is more common with RF ablation. motor weakness is more common with balloon compression. So these are the things that you should be clear about. So I've briefly described conservative treatment of trigeminal neuralgia. The next speaker will talk about surgical treatment with trigeminal neuralgia. Okay, so I hope that was helpful. So this is my team presently. These are the fellows who are there in my clinic right now. So thank you very much. Any questions, I'll be happy to answer, or we'll have questions after the second speaker. Thank you.
And I feel the questions are, if it is there, I am sure some questions will be there. So they can ask now. And later on also, these discussions can go on later on after Dr. Doe. So 1 or 2 questions quickly. Yeah. Any questions from the audience?
Sir, one question, sir.
Yes, yes.
Sir, good evening.
Yes,
sir, is it possible to have pain in all the divisions? Like I encountered a patient that he was not giving a very typical history. He was not giving, but she was telling she had this burning and some tingling in all the one side of the face, but in all the divisions, V1, V2, V3.
Okay, madam. See, trigeminal neuralgia in all 3 nerves are possible. So V1, V2, V3 trigeminal neuralgia is possible. But most commonly, when trigeminal neuralgia, at least the initial presentation, predominant symptom will be pain. Right? So if there is doubt in terms of diagnosis, we have to look for other conditions as well. We talked about atypical facial pain. There is something called sphenopalatine neuralgia. Cluster headache is possibility. So all these things have to be concluded. But the 2 answers to your question is V1, V2, V3 pain is possible in trigeminal neuralgia. 1. Second is trigeminal neuralgia pain is so severe. Usually, when it is actually trigeminal neuralgia, there won't be any doubt in terms of diagnosis. Patients will say mainly pain and usually not tingling or other features.
Yes, Karthik, I was going to add that part also. That normally the burning sensations are not there in the trigeminal neuralgia. It can happen in a very late stage. Burning can be a feature after we have done the ablations, the deappreciation pain, anesthesia dolorosa. That time it might be appearing, but initial presentation is not burning sensation. It should be sharp shooting, lancinating pain lasting for some time and then again reducing. This is the typical feature. But sometimes what you are telling is your confusion might be there. And I have seen physicians, when they are having some doubts, because carbamazepine is such a good drug for the trigeminal neuralgia. I have seen patients, physicians, I also have done 1 or 2 cases that, okay, give a trial of Tegretol, means carbamazepine. Carbamazepine is such a condition. If you are still having some doubt, you can prescribe carbamazepine and you can see, observe for a month or so and see how much relief is there. That also can clear your doubt. But what Dr. Karthik told, that is true, that it can happen in all 3 divisions, not that very common. But what is uncommon, what in your patient's presentation is burning sensation.
Yes, she was mostly not saying pain. She was saying some burning, some tingling, not pain exactly.
Only on one side.
Sir, I also only on one side. And even I prescribed carbamazepine, and she came after 1 month and she responded to it.
Okay, then it's fine. Then it's fine. Any other questions from anybody?
Sir, actually, she gave my history of like she ate something hard, and she was saying she had some pain at the angle of the mouth. Most of the time, she was pointing at the angle of the mouth.
Atypical, what you are telling, atypical facial pain is also a possibility. Atypical, if you are comparing about the burning pain, is common in atypical facial pain or the trigeminal neuralgia. My answer will be burning sensations are more common in the atypical facial pain rather than trigeminal neuralgia. And the carbamazepine can be effective in both the conditions. But whatever is it is, it is more effective. Carbamazepine is more effective in the trigeminal neuralgia. So whatever you have done, it's fine. And you have to rule out about the other secondary conditions with your MRI and all other things to look out that, okay, you are not missing anything else.
Yes, sir.
Yes,
Thank you,
one
sir.
other thing in addition to what sir said is facial pain. One of the important things that you want to keep in mind is dental origin pain. A lot of dental origin pain can present as facial pain. Since you said a history of some biting something hard and then the pain started, so one of the things that you want to keep in mind is things like temporomandibular joint syndrome. This is one of the differential diagnoses for facial pain, TM joint syndrome. So this is also something that you should consider. So facial pain, the common causes of facial pain are actually dental, then migraine, then these are rarer ones, the trigeminals, the cluster headaches, atypical facial pain, sphenopalatine neuralgia are relatively rarer. So dental pains have to be kept in mind.
Even cervicogenic headache can also present with the facial pain. Not very common, but can. Okay, any other question from anybody?
Excuse me, sir.
Yes, yes.
Sir told like trigeminal neuralgia is a clinical diagnosis. So MRI, is it necessary for each and every patient, or is it like during the treatment aspect only, like surgery or
Okay.
procedure?
So in principle, if you are a neurologist or a pain physician and trigeminal come, you can start treatment with neuropathic pain medicine and see. When the role of MRI comes is two important conditions. One is if you want to rule out a secondary cause, like if there is a intracranial pathology, a vascular lesion, a thrombosis, space occupying lesion, tumors. So when you want to rule out a secondary cause, MRI brain is essential. Second is if you are going for an intervention like a percutaneous procedure, RF ablation, or even a surgery. So if you are planning an intervention or when you rule out secondary cause, MRI is a very useful tool. Now, having said that, there is also some medico-legal implications. So if you are treating these patients for so many years and it's not responded, it's actually a better idea to do a MRI. So MRI has got three roles. One is to rule out secondary. Third is if you're planning an intervention. Fourth is medico-legally you will be safe. So if you're considering trigeminal neuralgia and there is also a vascular loop, then it confirms your diagnosis. That's your role. But it's not mandatory. Initial treatment you can do without MRI.
Okay, thank you. Thank you.
Okay, so I'll be asking Dr. Siris to introduce our second speaker, Dr. To. He's a neurosurgeon, and he'll be talking on the microvascular decompression. Particularly, he'll be talking about the useful points which will be practically important for pain physicians.
Thank you, thank you, Dr. Karthik. Now our next speaker is all the way from Malaysia. He's Dr. To Chang Jain.
Karthik, you can stay with us, or if you wish to leave, you can. And thank you for excellent presentation as always. You are a very good orator, and I am sure that everybody has enjoyed your lecture.
Okay.
Thank you, sir. Thank you for inviting. Thank you.
Good evening. Our next speaker is Dr. To Chang Jain. He's all the way from Malaysia. He's a consultant neurosurgeon and intervention pain specialist working in a Sunway Medical Center, which is a leading private medical center of Malaysia. He is associate professor of neurosurgery, as well as consultant neurosurgeon and endoscopic spine surgeon, as well as intervention pain specialist. He's also a founding and current president of Malaysia Society of Endoscopic Spine Surgery, as well as immediate past president of Malaysia Society of Intervention Pain Practitioner. And he has special interest in skull base as well as neuro-oncology and minimal invasive surgery, as well as neuromodulation and functional neurosurgery. He also has special interest in endoscopic spine surgery as well as other intervention pain procedures. And he has various articles published in national as well as international journals. I would like to welcome Dr. To Chang Jain to give us some insight about regarding surgical aspect of treatment of trigeminal neuralgia. Thank you, sir. Please, please proceed.
Thank you for the kind introduction. Can you hear me?
Yes, sir.
Can Okay. Thank you, Dr. Gautam, for inviting me. Now I would like to share my screen. Can everybody see my screen?
Yes, we can.
Yes, sir.
All right, thank you. Let me adjust a bit. Hold on. Okay, thank you, Dr. Gautam, for inviting me to briefly talk about the macrovascular decompression in the trigeminal neuralgia. Of course, I think this is a classical picture by our father of modern neurosurgery. There's a person with a severe trigeminal pain. But once you see this kind of expression in your clinic, you're almost quite certain. Because atypical facial pain, they don't have that kind of sudden stabbing, lancinating pain that the patient may tell you very pain, but they just talk to you like normal person. Classification of facial pain was actually by Dr. Bircher, showing that there's a spontaneous onset or trigeminal injury and other secondary like symptomatic trigeminal neuralgia like multiple sclerosis, herpes zoster, and then also atypical facial pain. In the spontaneous, they divided into two, whether it's episodic or constant pain. Trigeminal injury can be due to neuropathic, intentional or unintentional. Unintentional is like a motor vehicle accident with a facial bone fracture. Intentional is more or less after a surgery to the face, or maybe sometimes we can also have this kind of radiofrequency causes a differential pain. So basically, I would like to classify them again. Trigeminal neuralgia can be classified as a classical with a conflicting vessel and idiopathic with no conflicting vessel. Many times in my experience that when I do the surgery, even though the MRI showing there's a blood vessel very near to the dorsal root entry zone of the trigeminal nerve, but sometimes when in the surgery, we don't see an exact compression the nerve. So this is considered as idiopathic group. Of course, neuropathic pain, as I already explained, intentional, unintentional, and the rest of the others. The most important thing is whether this is a classical trigeminal neuralgia or idiopathic trigeminal neuralgia. So in the trigeminal facial pain, MRI is to look for any conflicting blood vessel and also to rule out any red flag condition. Of course, we can always start treating the patient with medicine. No need to have an MRI before we can start the treatment. And carbamazepine, I should call as a diagnostic medicine. With all the primary trigeminal neuralgia, all patients almost always respond to carbamazepine in the initial phase. Of course, with time, sometimes the carbamazepine less and less efficient, but in the beginning, it's always very effective. That's why I call it as a diagnostic medicine. So for this primary trigeminal neuralgia, we again all this classification. We have nerve preservation, we call microvascular decompression. The area of interest is dorsal root entry zone. And then of course, stimulator, as Dr. Karthik already explained. And idiopathic, usually we can use a nerve destruction procedure, mainly because there's no blood vessel for us to do microvascular decompression. Interventional plain procedure, like radiofrequency balloon compression, the target area is a glycerin ganglion. And of course, radiosurgery, gamma knife, which is very precise and accurate, is targeting the cisterna part of the trigeminal nerve. And of course, open surgery, which is actually old-fashioned. We open up the posterior fossa, and then we give some injury to the nerve. Sometimes patients are not very pleasant with this procedure because it also causes a lot of numbness. In the classical, we can also do interventional plain procedure, can also do gamma knife, not necessarily have to do microvascular decompression surgery. But in the idiopathic, we always have to warn the patient because there's no obvious blood vessel in the dorsal root entry zone. Microvascular decompression may not helpful or may not effective. However, as a surgeon, always we open up and then we don't see any obvious compression to the nerve, then we can give some squeezing of the nerve root to cause some neuropraxia and cause some pain relief at least for 1 to 2 years time, just like our interventional pain procedure. Other target is sphenopalatine ganglion, like Dr. Karthik already mentioned. Sometimes we use for idiopathic type of primary trigeminal neuralgia, traumatic, post-herpetic, and tumor. Of course, thalamotomy in a very severe, difficult cases with all exhausted with all the possible method, and tumor is tumor excision, obviously. Ideal procedure, we are looking at long-term relief or cure, intact sensation, low risk, and low cost. Unfortunately, we don't have the ideal procedure which fulfill all the criteria. So the more we think, the more we confuse what is the best treatment. This is a chart to show that there's anesthesia dolosa and painful dysesthesia, we call it a failure. Hyperesthesia is success, and ideal is intact sensation and pain-free. Of course, in hyperesthesia, also we consider as a success as long as patient not suffering in pain. So this is a paper to show that the comparison between microvascular decompression, percutaneous procedure, and also gamma knife, showing that the percutaneous procedure need more requiring a more additional procedure because the pain recur after two years plus minus. And about average number of procedure per patient to achieve relief, showing that the microvascular decompression and also showing there's a good outcome from the percutaneous procedure. Numbness, you can see the highest is percutaneous procedure, the lowest is microvascular decompression. And of course, the expenses is the lowest is a percutaneous procedure, highest is surgery, depending on the country and the charges of the country policy. Okay, decision making. The accurate diagnosis is very important, like previous Dr. Karthik already mentioned. We have to make sure that we don't wrongly diagnose atypical facial pain as trigeminal facial pain. Very correctly mentioned by Dr. Gautam that trigeminal facial pain seldom presented initially with burning sensation. Very seldom. They should always be having the lancinating, aggravating with chewing, or maybe talking and washing the face. If the patient can eat, can chew without any way to aggravate the pain, most likely it's not trigeminal facial pain. So we need to know whether it's classical, idiopathic, as I already mentioned. Classical can do MVD, but idiopathic have to talk to the patient very carefully regarding the outcome. And what is a causative vessel? Is it artery or vein? Is it the superior cerebral artery, or ICA, anterior inferior cerebral artery, or ectectic basilar artery, or vertebral artery, and also whether the nerve is displaced or not. There are so many blood vessels near to the nerve, but whether it is displacing the nerve or not, the more the nerve is displaced, the most likely the patient will be having a good outcome after the MVD. And we are looking at mainly the dorsal root entry zone, because in the cisterna part of the trigeminal nerve, we have a lot of blood vessels, but not necessarily cause trigeminal neuralgia. But if the blood vessel is stuck to the angle of the dorsal root entry zone, most likely it can cause trigeminal neuralgia. So in the MVD, microvascular decompression, positioning is very important so that we don't cause any unnecessary brain retraction and cause a lot of cerebellar edema, cerebellar hematoma. So we have two way of position the patient head, supine position with the head turned to opposite side, or park bench position. Park bench position because the lower arm is actually falling out from the edge of the bed so that the neck is not too much of compression, so that the venous return is good. And I always use park bench position because the brain is very lax and the head is very easily positioned. Because sometimes in a bit older patient, supine with the head turned to the lateral side may not adequately turn to the right side, turn to the lateral side may cause difficult in the trajectory of our instrument. So the most important thing is identification of asterium, is a combined joining of the three suture line, and usually you can draw a line from the zygoma to the external occipital protuberance, and that is the line of the transverse sinus. At the same time, if you feel there's a dimple there at the asteron, and then we know where is the asteron. Asteron is very important because it's a junction between the sigmoid sinus and the transverse sinus. And this is a key for success of the surgery. Because if you can expose the angle between the sigmoid sinus and transverse sinus, you are almost get the surgery done already, because that is the most important. Many people do the surgery a bit lower, then become more difficult to retract the cerebellum, because the cerebellum need to retract at the angle between the lateral wall and the superior wall. So that is a keyhole surgery principle. So the superior approach is very, very, very important, that we can expose part of the transverse sinus and the sigmoid sinus, junction of the sigmoid and transverse sinus, to indicate that you are adequately at the right position. Central approach usually used for hemifacial spasm. Inferior approach is usually we do for glossopharyngeal neuralgia. So that is a key of the craniotomy. So this is a planned craniotomy again at the junction of the transverse and the sigmoid sinus. And then the incision can be a lazy X, can be linear, but about 1 centimeter from the hairline or above the asteron or the junction between the superior and transverse sinus, and do a craniotomy. Usually I will drill the burr hole at the junction there. The moment I can see the junction between the sigmoid and transverse sinus, I know that I'm in the right spot. And then you have to open up the craniotomy, and then the dura have the design and cut at the edge of the sinus, so that you have to leave a bit of the dura so that we can suture it later on. Cutting the dura in this way will make the dura easily to suture post-operative. Otherwise, the dura will be shrink and difficult to suture. So the most important step after the craniotomy is opening up dura. After that, then is aronite dissection. Aronite dissection got few advantages. First, you can release the CSF so that the patient's brain is more lax and then easily being retracted. Normally, we don't retract brain. By release the CSF, the brain will anyway fall away from the operating site. And this is the most important dissection of the aronite membrane, so that we can clearly see all the cranial nerves. But having said that, we normally no need to see other cranial nerves. We just directly go to the angle of the tentorium and the petrous bone. You can already see the trigeminal nerve. Sometimes there's a vein before you see the trigeminal nerve. It's called superior petrosal vein, where you sometimes need to sacrifice, sometimes you can preserve. Because some studies show there's less than 1% of patients after sacrificing the superior petrosal vein can have a cerebellum edema, venous edema. But I haven't met one yet. I will try to save as much as possible, but if you can't save the petrosal vein, it's better to sacrifice in the early of the surgery, because any thorn in the petrosal vein will flood the operating site and make the operating site more difficult to reach the trigeminal nerve. So next is to identify all the possible artery. If you see there's an artery indenting the nerve and the nerve having some grayish indentation, then by decompress the artery from the nerve, you are almost always can get instant pain relief post-op without any medication need to continue. If you don't see the indentation, the outcome may not be as good as with the indentation. Of course, you need to dissect very carefully of the superior cerebral artery if there is the compressing the nerve. Also looking at all the possible perforators to the brainstem. You cannot turn the perforators because it may cause small area of brainstem infarct. And then after you decompress the SCA from the fifth nerve, and then you find a good space for you to insert the Teflon to cushioning the artery from pressing again to the nerve. Nowadays, I seldom put in between, but I try to use the Teflon to actually push away the artery and not even in contact with the trigeminal nerve, because sometimes with the scarring of aronite tissue, he may actually pull the nerve and cause subsequently pain in later day. So the most important thing is, this is a patient presented with a classical trigeminal neuralgia. after we do the MRI you have to order CIS 3D sequence, CISS 3D sequence. If you don't order CIS 3D sequence, you can't see the blood vessel clearly, whether it's actually compressing the dorsal root entry zone or not, or any blood vessel actually is there to cause the compression. Otherwise, you may think that this is the classical, and then you go in for surgery, you may not find the artery. So with this patient, many hospitals, they go, everybody say that this is a trigeminal neuralgia, somebody suggests for surgery, but I look at it, I know that it's no blood vessel for me to decompress, so I suggest for percutaneous procedure by using radiofrequency. I choose balloon only if the patient having a V1 or it's a secondary trigeminal neuralgia secondary to a brain tumor, because a brain tumor trigeminal neuralgia commonly cause all the 3 branch. Then I will use a balloon rather than radiofrequency ablation. So this is an example of the trigeminal neuralgia secondary to ectatic vertebral artery. You can see the vertebral artery is actually make a quite big turn, go up to the trigeminal system there and then coming down again to join with the basilar artery. So this is a video. If you can see, you can already see the trigeminal nerve is already compressed. You can see some grayish indentation there, knowing that that is the reason for the severe pain. So the ectatic vertebral artery have to be pushed away and to look around at the dorsal root entry zone. Is there any conflicting blood vessel is still there or not? If there is, you need to separate them. Otherwise, it can cause the residual pain or failure of the microvascular decompression. Then after that, then we prepare Teflon. After preparing the Teflon, then we find a good place to actually separating the artery from the nerve. Commonly, I will use a teaser glue to actually glue the Teflon so that the Teflon will not be misplaced after few pulsation. You can see I try to push away the ectatic vertebral artery, trying not even the Teflon pressing on the dorsal root entry zone, because the dorsal root entry zone is the cause of the pain. It's not really the cisternal part. You have to make sure that dorsal root entry zone is free, and then we can actually quite confident the patient will be having a pain-free after the surgery. I always off the medication instantly after the procedure. The patient will not feel any pain anymore, and then this is back to normal. Okay, this is another one, is a SCA. Same thing, you have to see the junction. Then you see this is the artery, this is a vein. This is a vein of the superior petrosal vein. I try to preserve, then I open up the aronite membrane. Then slowly you can see there's a trigeminal nerve behind the petrosal vein. Initially, I try to dissect the petrosal vein, hoping that I can actually avoid sacrificing it. But looking at it, it starts to ooze blood, and then I believe that it's better to sacrifice the vein rather than torn the vein. I will try to save the vein as much as possible. Dissect the aronite membrane out from the vein so that the vein can be easily mobile. But the problem is sometimes after few dissection, you can see it start to ooze. That time, I don't even bother to actually save the vein, because the more you mobilize the vein, the more the vein will torn. The more the vein torn, you start to bleed. Then this is some bleeding there. Otherwise, you can actually flood the whole operating field and then make the whole operation is more dangerous. Okay, behind that is your trigeminal nerve. Then aronite dissection is very important to do the microvascular decompression, because aronite, having a lot of aronite will be actually covering the artery, mobilizing the artery with the aronite membrane can sometimes torn the perforators. So first we have to make sure that the aronite membrane is nicely dissected. You can see a lot of branches from the artery actually supplying the brainstem. So this actually, you can see the artery pushing the nerve until you can see thin out of the nerve on your right side of your screen. Initially, I almost give up because it's so difficult to separate the nerve, the artery from the nerve. But without separating it, the patient pain will not resolve after the surgery. Now you can see it's a whole branch of the nerve, the artery can be separated from the nerve. And making sure that there's no perforators actually torn, otherwise is a possibility of getting a what do you call it, the brainstem. In fact, so far I haven't had one yet, but sometimes the small perforators sometimes can be very difficult to be separated. Okay, so the whole artery being separated from the nerve. You can see the whole branch, the whole curve of the artery is already separated from the nerve. Now is a time to put in the Teflon to separate the artery from the nerve, so that it doesn't touch the nerve, especially the dorsal root entry zone. Okay, I flip the Teflon so that the nerve is separated. Yeah, try to push away the artery as much as you can, so the nerve is quite free. There's no way the artery can go back to the nerve and cause compression. That is why a successful MVD actually almost can say is cure to the trigeminal neuralgia, except for idiopathic. Idiopathic sometimes is difficult. Even the opening is only about 2 centimeter. 2 centimeter opening. You no need to open big to reach the trigeminal nerve. So this is another picture showing the primitive trigeminal artery go straight to the Meckel's cave supplying in the anterior part of the cranial fossa, which is actually unable to separate. So I can only put the Teflon in between the nerve and the artery so that we can avoid the nerve direct pulsation to the artery, to the nerve. Sometimes oozing from the dura can be very irritating, but usually after you open up the dura, you turn the dura over it, and then this will actually stop the oozing. You can see the CSF is now flowing out, and with the CSF flowing out, then we can actually reduce the pressure of the cerebellum. Normally we turn the dura so that the dura tenting will open up the opening for us to easily go dissection into the trigeminal system. Brain retractor is called brain retractor, but I believe it's more or less a misnomer. We cannot retract the brain too much. You can see a tentorium now. Tentorium and the petrous junction there. Go inside, there's always a superior petrosal vein. Whether we can save or not depending on the anatomy, but no two anatomy exactly the same. They may not look exactly the same. So sometimes it's easy to preserve, sometimes it's difficult. So same thing, dissection of the aromatid membrane. At your right side, you can see vaguely some shadow of a nerve. The one is 7 and 8 nerve. You can see the artery is different from the previous artery because it doesn't have a loop. He actually directly go to the Meckel's cave that I believe is a primitive trigeminal artery that we cannot sacrifice. You sacrifice, you may have a stroke. So I have to find my way to actually put the Teflon in between so that the nerves are not directly in contact with the artery. You see the nerve, the artery is go directly into the Meckel's cave and go to the anterior cranial fossa. So after few dissection and few retraction of the artery, I decided not to pull some more because any pulling and start bleeding can be a disaster. So I just put a Teflon in between the artery and the dorsal root entry zone of the nerve, so that the dorsal root entry zone is free from any compression. Okay, I think we just skip here. Okay. Actually, trigeminal neuralgia can be treated with percutaneous treatment. Of course, microvascular decompression remains a gold standard to treat trigeminal neuralgia, but intercutaneous procedure is still having their role to treat trigeminal neuralgia. So what is the indication for patient for percutaneous procedure? Medically unfit patient for general anesthesia. A cerebellopontine angle tumor with trigeminal symptoms who underwent gamma knife treatment and refused surgical intervention. So we have to treat with percutaneous method because gamma knife cannot use for tumor and trigeminal neuralgia altogether, because gamma knife for trigeminal neuralgia, the grade is 80 grays, for tumor is about 24 grays. So with such a tumor there, you just cannot hit the nerve with 80 grays. So ultimately we use balloon decompression. Idiopathic neuralgia with no obvious artery compressing the fifth nerve. Patient preference, of course, financial constraints. So my last slide, preservation is always better whenever possible. Thank you.
So thank you very much, Dr. To. It was an excellent presentation, and particularly your algorithm, the classification of the different types of trigeminal neuralgia and the algorithm in which conditions, which procedures are better to do. Everything was very clear. And I'll be asking audience if they have any questions for Dr. To. And if Dr. Karthik is also there, he also can join the discussion. Dr. Karthik, if you are here. And any questions from the audience? So let me start the discussions with question to Dr. To. So suppose if a patient is having the classical, means there is having the blood vessels pressing the trigeminal nerves, but the patient is not willing to go for a surgery because it is an invasive procedure. So is a percutaneous technique is still be the choice, or it should be somehow convincing it and you should be avoiding the percutaneous technique? You have mentioned in your indication that in those situations, if the patient prefers for the percutaneous technique. Percutaneous technique means mostly the radiofrequency technique, because that is the commonest one. So that means if somebody is not interested to do for the microvascular decompression, even if it is a classical one, should he still go for the radiofrequency? Particularly if the patient is 40s or 30s.
I will let the patient understand that the few options of the treatment of trigeminal neuralgia. Younger patient, I will tell them that the chances of cure is high if there's a compression blood vessel, because with the radiofrequency I've experienced, they will come back again for the recurrence of pain. For gamma knife, sometimes they can have permanent nerve damage, because you can see in the study showing that the nerve fiber is reducing in gamma knife treatment. If after I tell them pro and cons, if the patient still wish to have a percutaneous, I believe that we have to go ahead. Otherwise, the pain, like what Dr. Karthik said, is a suicidal pain. They cannot have a normal life. And then I had to tell them that you have to understand that numbness of the face for percutaneous method are not complication. There is a price you need to pay for the pain relief, because in the study have shown that the more numbness you are, the chances of recurrence is lesser, or the duration of pain-free is longer. So they have to understand this. They cannot say that numbness is complication. I never tell patient numbness is complication, because you tell them it's a complication, they not normally like this word. Sometimes we have to use the word beautifully. I always tell them that it's a price you need to pay. So most of the time, they easily accept numbness when you tell them it's a price to pay.
Okay. And another question to both of you. Means one of the complication, which is a dreadful complication, I should say, that after damaging the nerve, there is a possibility of the deafferentation pain, where the pain might be increasing, burning, and other things might be increasing. So, how often in your clinical experience has came across to this situation that after doing a radiofrequency procedure, the patient came back with some new kind of pain, deafferentation pain? or sometimes this is also called the anesthesia dolorosa? How often in your clinical practice? Dr. Karthik and Dr. To, both of you.
In my experience, I have one patient. That one patient initially presented as an atypical facial pain. I convinced her again and again, telling her that don't go ahead with the percutaneous method. We should actually think of some other treatment method. Because nowadays, Google is so easily accessible, which initially is an educational platform, informational platform, now become a marketing platform. But people still believe in Google. So they use a Google explanation and presentation and describe the pain to me. But after I dig and dig, I know it's atypical, but they insist. They even go for microvascular decompression but fail. And they insist for percutaneous. I rejected few times, but he continued coming to my clinic. I said, okay, you have to bear in mind, you have 1% of anesthesia dolorosa, and your pain may not be successfully treated with the percutaneous method of your gasoline ganglia. They agree. But many pain patients, they always agree in the beginning, but they also blame you at last. You know, that's the problem. So ultimately, we do the percutaneous radiofrequency. Surprisingly, she told me that immediately after the procedure, pain is exactly disappeared. I normally hear this when pain 100% disappeared, I start to worry. Just like what do you get, tsunami, you know, before tsunami, everything is quiet. so I'm waiting for something serious happen. Ultimately, they come and blame me for doing a procedure because the face become a bit become numb, the tongue become numb and continuously pain. Then I tell her again, okay, now you know this, but don't go ahead to damage your trigeminal nerve further. She is so frustrated, she go for gamma knife by another doctor. I don't know how now, but he continued blaming me that damaging her life. The daughter is still young. So I would like to advise everybody here, if there is not a trigeminal neuralgia, try not to damage any nerve which is not naughty. Just like you don't scold your nice kids, they become naughtier if you scold them wrongly. If you want to scold them, scold the naughty kids. Normally they become better.
Okay, I'll be coming to this question. You know, another question is in my mind. I'll be coming to this question, but before that, I'll be asking Karthik to share his experience about the anesthesia dolorosa.
Yes, the anesthesia dolorosa is probably, I must have seen a few. Now, the thing is, this group is ones who are ones where you have done maybe 2 or 3 or more. So usually what happens is, when you do your first RF ablation, this is the way in my practice what happens. So the first RF ablation, when you do, this one works the best. So you have very good results. So when I say very good results, these are elderly patients with or without neurovascular compression, because they are 60 plus, which is most common the case. They're hesitant for microvascular decompression. So when I do the first one, very good relief. Most of them in my practice average 4 years, 5 years after first one. Then after some time they come back. So usually when we do an RF ablation, I tell only 2 things. One is there will be numbness. Second is this pain may come back. So these are the only things that I say when before I do the RF ablation. Patients are okay with that. So the patient comes back for the second time and okay, so you've tried conservative stuff again, it doesn't work. So you do the second one. The second one, if the first one works for 4 or 5 years, doesn't work for 4 or 5 years, that is a little less. So that's like 3 years or 4 years. And there are a group which I have done 3. Okay, so probably I've not done more than 3. Maybe if I grow a little older, I'll do more than 3 as well. So the ones that where we do more are the ones that eventually go into this anesthesia dolorosa, or eventually it becomes like a trigeminal neuropathy. So where their symptoms are a little smudged in terms of level. So they have symptoms in all 3 nerves. There is burning, there is tingling, there is shock, all sorts of things. So the system is very confused, and then it becomes very tricky to treat. So that's when there is some evidence where there is option to try pulsed radiofrequency, or there is also an option to consider spinopalatine ganglion block for anesthesia dolorosa. Now, if sometimes this anesthesia dolorosa involves the ophthalmic as well, then you are really in a fix, because you don't want to be touching too much and go into the ophthalmic nerve, because you can cause a bit of keratitis, and if this is not treated, this can cause corneal ulcerations as well. So these are the things that you should keep in mind. So hopefully you won't get anesthesia dolorosa, and second is you should be aware about the entity, and you should know about the treatment option just in case it comes up in your practice.
Okay, so already you have mentioned about the treatment part also of the anesthesia dolorosa. It's very difficult to treat, but sphenopalatine ganglion sometimes help, sometimes don't help. So this is a very miserable condition. You should try to avoid it. Another question for both of you is, suppose you are doing a secondary trigeminal neuralgia, like some tumor. So will you prefer percutaneous technique if it is a tumor compressing any of the path of the trigeminal region? And related to this question to Dr. To also, that if it is a atypical facial pain, if the pain is coming one part of the one side of the face, the area is supplied by the trigeminal nerve only, means innervated by the trigeminal nerve only. So why not the atypical facial pain, the trigeminal ablation is not a choice? So I'm trying to relate these two questions together. Means pain is coming because of the cancer of any part of the face or any part of the compressing that nerve. Are you going to do the RF ablation? And second part is, if pain is coming in any part of the face, and if we are doing a theoretically it looks nice, no, that okay, pain is coming from the face and face is innervated by the trigeminal nerve. So why can't the trigeminal nerve block will help in these situations? So these questions are two related questions. So I want your opinion regarding these two questions, both of you.
Okay. For me, when there's a atypical facial pain, I will always use the sphenopalatine ganglion first. That is,
yes, it is obviously the one of the evidence-based treatment for the atypical facial pain. But my question is, if the pain is coming from the part of the face, maybe because atypical facial pain, or maybe because of some tumor or cancerous growth, can trigeminal neuralgia help, or whether should we avoid in these conditions? Where to avoid, where to do?
if there's a tumor compressing or the tumor eroding or invading the nerve, I think the trigeminal ganglion ablation is reasonable. Just like I mentioned before, if you have two kids, one is a good kid, another one is a bad kid. If you are not sure which one is the bad one, don't scold the good one. Otherwise, it will give you more headache. So if I'm not sure which one is the problem, I will target the sphenopalatine. If there's a tumor there, I think gastric ganglion is a good choice because the nerve is being compressed. So we consider that as a bad hit. It's never wrong.
If there is a situation, say for example, somebody is having a malignancy of the maxilla. So it is not any compressing any nerve, but having the severe pain in the region of the maxilla. So shall we still go ahead with the trigeminal ganglion, the gastric ganglion block?
Yeah, if it's actually accessible, if the tumor not in your way, doesn't cause any bleeding in the tumor, I would choose that, because if the tumor already near or invading the nerve, I think gastric ganglion is a good choice.
Okay, so Karthik's view on those 2 points.
Okay, so even though a question is asked together, I'll answer them separately. Now, the tumor, what happens is, India is a country where we are a country of pan chewers. So the tobacco makes oral cancer the most common cancer in India. Now, we see all sorts, we see cheek, we see throat, we see tongue, we see pharynx, all sorts of cancers. Now, very common to find patients with maxillary or cheek cancer who come with pain. Now, my experience with this group is, there is pain in the distribution of the trigeminal. There is also pain which is caused because of pressure effects in the maxilla. So whatever blocks I have done, where I have, see, cancer pain, there is a bit of trial and error. Sometimes you try it works, sometimes you try it doesn't work. So whatever little where I have done trigeminal blocks for cancers involving the maxilla, at the end of the day, these patients came and said, the place is numb, but my pain is persisting. So probably the reason is because it's because of pressure effect or there is a central component to it. So in my way of doing it, if there is a cancer involving the maxilla or the cheek, I'm better off doing a stellate, which is a sympathetic block to the face, than trigeminal. For atypical facial pain, I would do a diagnostic phenopalatine, and if it is positive, I'll go for an RF ablation. So this is my way of doing it.
Okay, so the other situations are very typical. Atypical facial pain, definitely the sphenopalatine ganglion block has good evidences. So if there are any questions from...
May I ask questions, sir?
Yes, yes.
Sir, this is for Dr. Karthik. Many of time we see patient with post-herpetic trigeminal neuralgia. So what are your thoughts regarding line of management in these post-herpetic trigeminal neuralgia patients, sir? And another,
Okay, now post-herpetic neuralgia can occur along any nerve after herpes infection. Now, post-herpetic is notorious to occur in the ophthalmic division, so it becomes post-herpetic ophthalmicus. So this is fairly common. It is also possible for patients to have post-herpetic neuralgia in V2 and V3 as well. Now, V2 and V3 to do an RF. Now, remember, post-herpetic is very, very, very difficult to treat. This is a peculiar type of neuropathic pain. There is a central component to it. Now, usually post-herpetics, as much as possible, I like to treat them conservatively. Now, also remember the graph of the post-herpetic. So the post-herpetic pain starts after 1 or 2 weeks, and then the graph peaks at around 3 to 6 months. And after 1 year, majority of patients settle down. So if you see the original the history, what the ratios tell us, about 40% of patients with herpes infections will have post-herpetic neuralgia. And among this 40%, after 15 months or 2 years, the data comes down to almost 3 or 4%. So majority of these patients will settle down after 1 year, and if not after 2 years. So there is only 3 or 4% of patients who have post-herpetic who have pain beyond 2 years. Okay, so this is a good news. So as much as possible, post-herpetics, I like to treat them conservatively, because whatever experience I have, we don't get great results with interventions in post-herpetic. Correct? Now, the more later you're going to see these patients with post-herpetic, the more worse are the outcomes, because your interventions, if it is done reasonably early, likely to have good outcome. The ones after 2 or 3 years, very bad outcome. So as much as possible, post-herpetics, I like treating conservatively. One. Second is, probably if conservative is not working, V2 and V3, I don't mind doing RF ablation. If it's a V1 or post-herpetic ophthalmicus, you can't do an RF ablation for obvious reasons. You have an option of balloon compression or a glycerol injection. But if this patient's pain is not too severe, and if it's manageable with neuropathic pain medicine, I would just bide time, hoping that they become better by themselves. I'm not very fond of doing interventions in post-herpetic.
Thank you,
So
sir.
I agree with Karthik also. I have treated few patients, and as Karthik told, these are very notorious. The failure of the interventions are very high, whatever you do. So one of the options is doing the V1 division ablation, but another intervention mentioned in the literature is your sphenopalatine ganglion block. Also, that has very high failure rate. I can remember few patients, I have done both also. Even then, there was no results. And nowadays, if in this kind of patients, I always try the medications and wait for the spontaneous remissions, asking the patients to pray the God, so that the remissions are quick and early. Otherwise, interventions has a very notorious results. Dr. Toe is going to tell something, his experience about herpes.
Yeah, I agree with Dr. Gautam. Commonly, I will try on the sphenopalatine. But one thing I want to ask is, if the sphenopalatine is very effective after a pulse RF, I always worry about giving an ablation at the sphenopalatine, because it's so near to the mixed nerve, the maxillary nerve. Any tricks or any tips can share that we can actually only ablate the sphenopalatine and not injure the rest of the mixed nerve?
So, but the maxillary divisions by the stimulations pattern, we can avoid it. So if we are getting the stimulations along the, near the palate, near the cheek, then we have to understand that we are close to the maxillary nerve, and we have to reposition the needle, bringing the needle down. Because the sphenoparietal ganglion block is hanging from the branch of the maxillary. So if you are going up, then you are close to the maxillary division. So we are trying to bring it down. So that is the only thing. Only acceptable paresthesia is the root of the nose. So that is the only acceptable one. But still there is a possibility that we can still ablate the maxillary nerve because it is very close. And okay, pulse if my experience with the sphenopalatine, I told you, is not good. So that's why I have stopped several years. I completely stopped it because the results are not encouraging. And if you are searching the literature also is telling that, okay, the results for all the different kinds of interventions like the V1 divisions ablations or the sphenopalatine ganglion pulse RF or the conventional RF, both have the very high failure rate. Some patients have the results. I can remember one of my patients got good results initially. After that, I was encouraged to do few other patients, but it didn't work. So this is my suggestion that, okay, the intervention should be avoided as much as possible in the herpes zoster of the first division.
So do we use a very short active tip for the sphenopalatine ablation?
Yes, 5 millimeter active tip.
Okay.
So one more question, sir. So for Dr. Karthik again, so while doing thermal ablation, especially conventional RFA for trigeminal nerve, either one or two nerve, do you rotate the needle so as to increase the size of lesion, or just go for one thermal lesion per nerve, like depending upon the temperature, 60, 65 or 70, or do you rotate the needle in 3 or 4 rotation so as to increase the lesion as well as increase the duration of pain relief?
Yeah. So one of the things that we tell patients before doing an RF ablation, I just mentioned it briefly, is post-procedure, there may be numbness. I usually don't say there will be numbness only in that dermatome in which they have pain. I say numbness in that side of the face. Okay, one. So when we do ablation, my kind of practice is such that my patients want one good long-lasting block. So what I generally like to do is I like to do a very good lesion. I don't mind if the dermatome or if I'm doing V3, V2 is involved, I don't mind that at all. So what I normally do is I do with the 5 millimeter tip. So I first get a good stimulation. Once my position is happy, I do give the local anesthetic, and then I flip it around a few times and I do 5-6 lesions. So I don't mind blocking the nerve that is beside because I want to do one lesion. So my flipping around the curved needle 180 degrees and then pulling it out and doing one more or 3 or 4 lesions, flipping it 180 degrees is to increase the lesion size, thereby prolonging the analgesia. I'm more interested in prolonging the analgesia safely than being very particular about only that V2 or V3. So that's my way of doing it.
Sir, and do you have any favorite active tip regarding trigeminal? So people are going for one nerve, they are going for 2 millimeter, two nerve, they are going 5 millimeter, and 3 nerve.
I don't use 2 millimeter at all, and I don't use pulsed at all. This is only my way of doing it. So I preferably use the 5 millimeter. There have been times when V2 and V3 are involved, really bad trigeminals, where I've used 10 millimeter also, but probably not. I would recommend 5 millimeter is what I would be comfortable with, not 2 millimeter. 2 millimeter is too small for comfort.
Thank you.
This was my experience same. That initially when I started my the career practice, I used to take the 2 millimeter active tip because 2 to 5 millimeter is the recommendation. But over the period of years, gradually I understood how you told that okay, if another division or little bit of third division or little bit of second division is overlapping areas is becoming numb, we don't mind, but patient should have a long-term pain relief. That is the goal. So the duration as well as the success increases if we are doing a larger size lesion. And what I do nowadays, that if it is a V3 division is involved, I always use the 10 millimeter. And if it is only V2, if it is V2, V3 combination, then also I use the 10 millimeter. If it is only V2, then I use the 5 millimeter. Otherwise, I have seen that the 10 millimeter active tip, even in the V3 division, is giving the much better result and long-term results compared to that. So that means my journey started with the 2 millimeter, and now I am in the situation where I prefer 10 millimeter because it gives better result to the patient, to my patients. Dr. To, do you have any experience on this? How much is your active tip you are using in your patients?
I seldom ask unless there's no needle available. Otherwise, I will try to use 5 millimeter. I worry about too much of damage. I don't know. I rather to be more conservative. If the patient come back with some pain, I a bit too worried because of that one patient of anesthesia dolosa. I start to worry already because the one I use 10 millimeter, and then in fact the patient is quite awake. I asked whether the after I just put a needle there and ask how is your sensation, is it reduced or not? He said no. Then I burn again second time. I believe the multiple burning and the temperature maybe cause this nerve damage even more. The patient also don't know why. There's no numbness, nothing, and then suddenly becomes so painful.
Yes, I have also seen that if the numbness is there, then your success will be there. If there is no numbness, the patients might not be landing up with this. More question for Dr. To in the chat box. Is surgery in the post-percutaneous procedure, that means somebody has underwent the radiofrequency procedure, is this procedure is making surgery difficult? Because this is the question sometimes asked by the patient or sometimes by the other doctors, that if you have, suppose somebody is having the classical trigeminal neuralgia, vascular loop, and the pain physician have done an RF procedure, is it making the surgery more difficult if they are doing the trace or something?
No, because the percutaneous procedure, the target is the gastrin ganglion. Our surgery target is the dorsal root entry zone. So these two different places.
Surgery target is much more proximal, and the radiofrequency is much more distal.
Yeah. Another thing, but the thing is, if the patient develop the kind of a numbness pain, the surgery maybe have to cautiously warn the patient, because a numbness pain, it may be because of the neuropathic pain, is no more a neuralgia. Then neuropathic pain, even though you take away the causative blood vessel, may not relieve the pain. And the numbness will not improve after the surgery. The surgery is by the nerve recovery. The numbness,
Any other questions from audience?
So even if it's not a RF, if it's a glycerol, if glycerol is used.
The glycerol are supposed to be stay in the Meckel's cave, are not supposed to leak into the subarachnoid space. If they leak into a subarachnoid space, it's a disaster because it can cause a lot of arachnoiditis and a lot of brainstem irritation. So you still stay in the Meckel's cave. That's why in the glycerol neurolysis, once you see the glycerol is a CSF leak, normally they will not do the glycerol neurolysis. But in the radiofrequency, even you can see CSF leak, you can still burn, no issue.
Thank you, sir.
That means the bottom line is, if you are doing the CSF, correctly doing the glycerol neurolysis, that also should not make the surgery difficult. Am I right?
Yeah.
Sir, one final question, sir. One question.
Okay, one question from in the chat box. What is the dose of the glycerol neurolysis? So, okay, so glycerol neurolysis, the dose is very minimal, less than 1 ml. Normally, we give 0.6 to 0.8 ml of glycerol. Not much, less than 1 ml.
Sir, one question regarding conservative management, sir. For Dr.
Yes.
Sir, yes. Suppose a patient came with trigeminal neuralgia and we started using carbamazepine or oxcarbazepine, but the dreadful complication of Stevens-Johnson didn't occur, but persistently he's having hyponatremia. So what will be the second line of drug if the patient is having only hyponatremia and patient doesn't want to go for RF or surgery? So is there any medical management for these group of people, sir, for hyponatremia with carbamazepine and oxcarbazepine?
So, carbamazepine-induced side effects, one of them is something called SIADH. SIADH is a long story. I can't tell you what is SIADH now, but SIADH patients do end up with hyponatremia induced by carbamazepine. Now, in this group, if they are going in for hyponatremia persistently, there have been times when we have tried other medication, which includes gabapentin, phenytoins, and even pregabalin. There have also been a group where they have not tolerated this medicine, and we have managed to supplement these patients with sodium tablets to compensate for the hyponatremia. But if your patient is not tolerating, in spite of a reasonable amount of adjustment, this is one of the indications where you should consider an RF ablation or a surgery. So, if your patient is not tolerating medication, so we do know that carbamazepine-induced Steven-Johnson is there, carbamazepine-induced allergic reaction is there, SIADH-induced hyponatremia, these are all known complications. So, if they are not able to tolerate, try to substitute the neuropathic pain medicine. If the efficacy is still not good, think about intervention or surgery.
Thank you, sir. Thank you.
Usually the patient is pain enough, they normally agree for intervention. If they are not pain enough, then just continue medicine.
Any other questions from anybody? No? Okay, thank you very much, both the speakers.
Thank you.
Thank you for joining, and it was a wonderful, excellent lectures by both of you, and very good discussion. I am sure that everybody has, enjoyed it. So this side is your caudal side, this side is your cranial side. So this camera, below camera, on the right hand side is focused from the foot end, and this other camera on this top of the right hand side is focused from the cranial side, so that you can have a better visibility of both this camera. What I can do is, I can put this camera a little bit from here, so that you can, and then close look. Okay, I hope now both the cameras, the visibility is now good. The other camera which is zoomed out is just to see you how the serum is positioned. So that right hand top camera is for that purpose, and this camera is for the closer view of your on the patient. So our target is what? Our target is foramen, because Gastrin ganglion, it is having the 3 divisions. So the third division is coming out through the foramen oval, that is the mandibular division. But that is the division, that is the foramen through which I can access to the Gastrin ganglion. What are the other 2 foramens through which the other 2 division comes out? So V1 division comes to the superior fissure, the V2 divisions for the foramen rotundum, but they are not accessible. They cannot go enrich the Gastrin ganglion through this foramen. So your option is only to enter through the foramen oval to go closer to the Gastrin ganglion, but Gastrin ganglion is coming, only the 3rd division is coming through the foramen oval. But I can reach there by the foramen oval. So where is foramen oval is situated? Foramen oval is situated over the where? In the sphenoid bone, base of the skull. So very big foramen. So here, I was trying to show you the foramen oval here. So if I am removing this, if I am seeing this, the base of the skull, so this is the foramen oval. So this is the foramen oval. Yeah, this is the foramen oval. But how to see there? How to access there? I cannot access from here. The way of accessing the foramen oval is where between this side is your the maxilla and this side is your mandible. So this gap, I have to make the gap wider by turning the ipsilateral oblique, and then can you see the foramen oval there? Deep there. This is the foramen oval. So I have to make the rotation of this serum in such a way so that I can increase this gap between the maxilla and the mandible. So you can see if the patient is turning like this, and if your serum is AP view and you are not doing anything, so you will not be able to see the foramen oval. So the 2 movements are important for your see. One is you need to see from the caudal side. from the caudal side, so that you can see the base of the skull. And second is you have to make it so caudal side, and you have to make it this way. You cannot see it nicely, so you have to make it the ipsilateral oblique, or turning the head to the other side, so that you can see the foramen oval nicely. So the thing is, foramen oval must be seen nicely. If you can't see the foramen oval, you cannot do the procedure. So earlier days, when the CM was not popular, people used to go there and tell that, okay, your needle should be towards the people, towards in this plane, towards the tragus in this plane, 2 to 3 centimeter from the angle of the mouth. Those things are obsolete. So you don't know to do these things. All those landmarks, things, all to do it blind technique. Go and hit the foramen, the base of the skull, and then the walk over the base of the skull or the sphenoid bone and try to search out the foramen oval. Those days are over. So here you have to find out the foramen oval. And once you are seeing the foramen oval, your needle entry point will be over the foramen oval. So that is the trick. And if you can't find foramen oval, please don't try it. You cannot do anything if you are searching, if you are unable to find out the foramen oval. Sometimes it becomes difficult, but I always tell that if you are unable to find it out, please go back to your home page. Start from the AP view and again follow the steps. So what are the steps? So first, this is an AP view we are taking. And in the AP view, so in the AP view, so we are looking, we cannot see any foramen oval here. So in the AP view, what we are seeing, this is the the mandible, this is the maxilla, and this area I'll be searching, but I have to do this, this area bigger. And one thing is called known as the submental view. What is that submental view? Submental view means the CM will focus below the mandible. And what I tell, this is one of the trick what I always do, that try to see this mandible, here it is almost straight line. Try to see it as an inverted V, like this, inverted V. When you'll be seeing it as an inverted V, that is the end point. You did not make it more caudal tilt. So your option is either you do a reasonably the good amount of the caudal tilt, or you extend your neck. If you're extending your neck, then what you need to do, you have to make a less caudal tilt. So here will be rotated, the caudal, so that you will be able to see it better. So let me remove this, erase this drawing. And so here, initially my CR was in the AP view. So now what I'm doing, I'm trying to make it a caudal tilt. So I'll be trying to focus it from the leg side. Let me make this camera a little, zoomed out, so that you can appreciate it. You can see how the CR is being oriented there. So what I'm doing, I'm trying to make this as an inverted V. This. So now we have done a reasonably good amount of the caudal tilt, and we no more caudal tilt is needed. Now this is the area. This is my area where I need to search for the foramen oval. So what I need to do, the second phase, now I'll be making it oblique towards me. So now see, now the foramen oval is very nicely seen. So here is your foramen oval. So caudal tilt can be a little bit of less caudal tilt. Okay, so the foramen oval is nicely seen now. So you just make a little bit of more and less radial tilt to see that. Okay, so now you can see the foramen oval very nicely, and this is our target. This is our target, and I'll not be measuring anything, how much from the medial, how much from the angle of the mouth. So that is not important. Important is I'll be putting a radiopaque marker over the foramen ovale.
Excuse me, sir. We can't see the lower feet, sir. Only.
Okay. I might just in the camera.
Thank you, sir.
Okay, I hope you can see now.
Yes, sir.
Okay, so my middle entry point, I am just putting a marker there. And I'm not measuring anything, how much from the angle of the mouth or nothing. I'm just putting it and trying to make this needle in tunnel vision. In tunnel vision. Some says that okay, hit the the margin of the bone there for and then you can go. Or some says that okay, don't need of hitting it over the margin, you can straight away go inside it. Okay, I'm not. It's not tunnel vision. I'm just trying to make it tunnel vision. Okay, so at this point, I'll be going into the lateral. The lateral view will be now showing you that okay, exactly what. So I'm hitting the foramen ovale and now I have crossed the foramen ovale. So here the important bony landmark. So this is your pituitary fossa, sella turcica. This is your anterior clevis. This is your posterior clevis, and this junction. This is your the zygoma. So your needle should be crossing this black area. This area is little bit of less radiolucent. Most of the patients, patient to patient can vary. Sometimes this area is very nicely seen. Sometimes this area is not nicely seen. But your needle should never cross this one. If you are crossing this line, then you are going to touch or hit and damage the brainstem. So brainstem is here. So you cannot cross this line. Your needle should be coming here and stimulating it. Okay, so I'll be checking again by my original position. So foramen ovale was here. Foramen ovale was here. So initially I was touching the bone and then I slipped it. Sometimes you may not touch it, directly go in. So lateral view is important for advancement of the knee. I take off the position. Okay, so that was the foramen ovale. My needle is there. In the foramen ovale, ultrapyrogram. Correct. Okay, so that is the foramen ovale and my needle is in the tunnel vision exactly over the foramen ovale, and the lateral view I have confirmed that I have crossed that foramen ovale area and my needle is not too deep. So that is my final needle position. Okay, everybody understood how to do it? So first is always start with the AP view, then make a cranial tilt, a caudal tilt, sorry. So make it caudal tilt on this side towards the leg side, and you try to see your the foramen ovale from the towards your foot end, because this is the base of the skull. So base of the skull, you have to see it from the foot end. So you have to make the CM towards your the leg side, and then you make it ipsilateral oblique or turn the face to the other side. Turn the face to the other side or make it ipsilateral oblique, or you can do both the things. You can turn the head a little bit on the other side and make it oblique, and you go ahead and identify the foramen oval. Nothing to measure, nothing to see that okay whether it is in the prepuce direction, tragus direction. Nothing is needed. Your needle should be directed towards the foramen oval. So you have to find out the foramen oval. Unless you are finding out the foramen oval, you should not do the procedure. And once you are seeing it over the put a marker there, and then go directly, hit the margin or may go directly, and on the lateral view you should be crossing the foramen oval area, but you must not be crossing the line drawn from the posterior clevis. Okay, I hope everybody has understood it.
Yes, sir.
Now we'll be demonstrating the sphenopalatine. So shear movement is very important. I am repeatedly telling that okay, you have to identify the foramen oval. That is the key. If you can identify the foramen oval, the rest of the things are very easy. But if you can't, then it is difficult, and don't try to do it unless you are identifying the foramen oval. So please don't do the procedure, abandon the procedure if you can't see the foramen oval. And the trick is starting it from there. Once you are there, unable to find it out, don't move it here and there. If you can't see it, then go from the home page, start from the AP, and again step by step you go. Okay, so now we'll be seeing the sphenopalatine ganglion. For the sphenopalatine ganglion, where is sphenopalatine ganglion is situated? It is situated in the sphenopalatine fossa. So where is sphenopalatine fossa? Sphenopalatine fossa is posterior to the maxillary sinus, and we have to see the slit of sphenopalatine fossa, and sphenopalatine ganglion is situated there, and it is, as we were discussing, that it is hanging from the maxillary line.